Finals SAQ 93, Continuous Epidural Analgesia. What are the complications of CEA in the ward setting? These include opioid-related, such as pruritus, respiratory depression or respiratory arrest, LA-related, high block with CVS collapse or respi arrest, hypotension, urinary retention, motor block, pressure sores and LA toxicity, catheter-related, such as unexpected development of high block due to catheter migration or intrathecal injection, postdural puncture headache and subdural hematoma, superficial infection around insertion site, epidural hematoma or abscess, meningitis, spinal cord ischemia, permanent harm such as paraplegia and nerve injury. Last is human factors or organizational issues such as drug administration errors and inadequate analgesia. Incidence of complications of epidurals: epidural failure 1 in 20, hypotension 1 in 50, headache 1 in 150, temporary nerve damage 1 in 2000, permanent nerve damage 1 in 15,000, epidural abscess 1 in 50,000, meningitis 1 in 100,000, epidural hematoma 1 in 150,000 and paralysis 1 in 250,000. B. How should patients be monitored throughout the period of CEA? Monitoring aspects includes clinical and organizational. Clinical parameters includes heart rate, blood pressure, respiratory rate, sedation score, temperature, pain score, motor and sensory block, pressure areas, venous cannula patency, epidural site, and pump prescription and volume given. Organizational factors includes trained nursing staff able to deal with complications, acute pain team review and management, 24-hour anesthetic service, handover of ongoing CEAs, ongoing duty of care by the anesthetist who sited the epidural. Ward must be adequately staffed, patient close to nurse's station, protocols with action plan in event of abnormal observations, and more frequent physiological observations in the first 12 hours and after top-ups or changes in infusion rate, periods of CVS or respiratory instability. C. Outline the safety features that relate to equipment used for CEA. Equipment should be standardized throughout the healthcare center and staff training. NPSA 2009 recommendation that equipment for neuraxial and regional anesthesia or analgesia should not connect with IV luer connections or IV infusion spikes. Regarding pumps, they should be configured for epidural analgesia only in milliliters and labeled as such, with preset limits for maximum infusion rate and bolus size, lockout time, alarms for air, end of infusion and high pressure, lock box but able to see the fluid without unlocking, lock code required for programming and bolus administration, and documented maintenance program. The epidural infusion system should be closed with no injection ports. Antibacterial filter must be functional. The infusion system must be labeled as epidural with yellow label, with yellow stripe to infusion system and anti-siphon valve. The epidural kit should have a standardized needle with markings, Huber tip with blunt leading edge, stylet and wings, low resistance syringe. Connector should be securely fastened to minimize risk of breaches in the circuit. The catheter should have a blue blunt tip with multiple fenestrations and standardized markings. The epidural kit should be sterile with expiration date. Dressing should be secure with no breaches and sterile with expiration date. 70.4% pass rate. The question was based on best practice in the management of epidural analgesia in the hospital setting, November 2010, published by Faculty of Pain Medicine of Royal College of Anaesthetists. Additional information: NAP3, Major Complications After CNB, 2009. Key findings: 700,000 CNBs are performed annually in the UK, 46% are spinals, 41% are epidurals, 45% are for obstetric indications, and 44% for perioperative indications. 84 major complications were identified, 2/3 made a full recovery. Of the 30 permanent injuries, 60% occurred after an epidural, 23% after spinal and 13% after CSE. Incidence of permanent injury, 1 in 24,000 to 54,000. Incidence of paraplegia or death, 1 in 50,000 to 140,000. Patients who had vertebral canal hematoma and spinal cord ischemia had a poor prognosis. Contributors of harm includes failure to follow published recommendations, failure to identify and understand the relevance of inappropriately weak legs, including unilateral weakness after CNB or during continuous post-op CNB. Organizational deficiencies contributed to delays in diagnosis and intervention in several cases. Aspects includes failure to monitor, poor understanding of abnormal findings by nurses and doctors, poor interdepartmental referral processes, scanning equipment which was routinely unavailable, out of hours or broken, and lack of availability of beds in tertiary referral centers for patients requiring specialized emergency surgery. Regarding ESRA guidelines for regional anesthesia in patients on antithrombotic drugs, nerve blocks were divided into deep nerve blocks and superficial nerve blocks. Notable deep blocks includes neuraxial blockade, infraclavicular, paravertebral, lumbar plexus, quadratus lumborum, sacral plexus or proximal sciatic, and PANG blocks. Regarding management in high bleeding risk blocks, which includes neuraxial and deep nerve blocks, focusing on time of last drug intake to intervention. For warfarin, it should be 5 days and until target lab value such as INR less than 1.5. For low-dose direct 10A inhibitors, it should be 24 hours for rivaroxaban and edoxaban, or 30 hours if creatinine clearance is less than 30. For epizaban, it's 36 hours. For high-dose direct 10A inhibitors, it should be 72 hours or until target lab value, DXA level less than 30 nanogram per ml, or anti-10A less than 0.1 international unit per ml. For low-dose dabigatran, it should be 48 hours. For high-dose dabigatran, it should be 72 hours or until target lab value, which is less than 30 nanogram per ml. Alternatively, thrombin time should be in normal range. This is mandatory in creatinine clearance less than 50 ml per minute. For low-dose molecular weight heparin, it should be 12 hours or 24 hours if creatinine clearance less than 30. For high-dose low molecular weight heparin, it should be 24 hours or 48 hours if creatinine clearance less than 30 or anti-10A less than 0.1 international unit per ml. For low-dose unfractionated heparin, it should be 4 hours. For high-dose unfractionated heparin, it should be 6 hours if IV, 12 hours if subcutaneous, or until target lab value, APTT or anti-10A or ACT in normal range. For low-dose fondaparinux, it should be 36 hours, or 72 hours if creatinine clearance less than 50. If high-dose fondaparinux, intervention should wait until anti-10A is less than 0.1 international unit per ml, which takes about 4 days. For low-dose aspirin, there are no time limitations for deep nerve blocks. For high-dose aspirin, time from last drug intake to intervention should be 3 to 7 days. For P2Y12 inhibitors, it should be 5 days for ticagrelor, 5 to 7 days for clopidogrel, 7 days for prasugrel, or until target lab value. For further details on perioperative management of antiplatelets and anticoagulants, a good reference is AHA 2024. Considerations includes risk of bleeding, risk of thrombosis, especially for coronary stents, whether there is a need for bridging therapy for patients with high risk of thrombosis, such as recent TIA or stroke within 1 month, or certain mechanical heart valves, or CHA2DS2-VASc score more than 7, may need bridging therapy after consult with cardiology. Another consideration is timing of restarting anticoagulants and antiplatelets after the operation. The risk-benefit analysis requires multidisciplinary discussion. Regarding low risk of bleeding blocks, i.e. superficial nerve blocks, ESRA recommends no time limitation from last drug intake to intervention. Additional information on critical incidents. What is an error? An error is an act that can lead to an undesirable outcome. Medical error is a preventable adverse effect of care. Errors may be classified by process resulting in the error, intent, personnel involvement, and time of occurrence relative to identification. Errors may be latent or active. Latent error lies dormant before situation arises in which it is identified. Active error, action directly causes an error in real time. Unsafe acts can be subdivided as unintended and intended. Unintended, unsafe acts includes sleep, attentional failures in familiar skill-based tasks, or lapse, memory failures in complex tasks. Intended unsafe acts may be mistake, rule or knowledge-based mistakes, or violation, routine deviations, and malevolent acts. What is critical incident? A critical incident is an active error with significant consequences. A patient safety incident is the potential or actual harm due to any healthcare event. What are some factors that predispose to critical incidents? This includes patient, disease or management, and environmental factors. Patient factors includes altered capacity and ability to communicate, impaired defenses such as sedation, and reduced reserve to mitigate consequences of errors. Disease or management factors includes unstable and high-risk conditions, requirement for invasive procedures, multiple medical devices, and high load of parenteral or enteral therapies, or polypharmacy. Environmental factors includes high acuity, high patient turnover, and vulnerability to interruption and distraction. What is a never event? This is a specific type of critical incident that does or may result in severe harm or death, is a known source of risk, has existing national guidance and safety recommendations, is preventable if these are followed, and is easily identified, defined, and measured on an ongoing basis. Examples includes misselection of strong potassium solution, administration of a medication by the wrong route, overdose of insulin due to abbreviations or incorrect device, overdose of methotrexate for non-cancer treatment, misselection of high-strength midazolam during conscious sedation, chest or neck entrapment in bed rails, transfusion of ABO incompatible blood components, misplaced nasal or oral gastric tubes, scalding of patients, and unintentional connection of a patient requiring oxygen to an airflow meter. What steps should be taken if a critical incident has occurred? This can be divided into patient and family, the doctor, documentation, the team, department, and hospital. First priority is patient care, declare crisis, call for help, stop trigger, ABCDE assessment and stabilization, diagnosis and treatment of causes, and post-crisis management. There should be open disclosure, according to duty of candor, inform the patient or representative as soon as possible. A mnemonic for breaking bad news includes spikes and grid, ensure private setting without interruption, greet and establish rapport, reassure and acknowledge concerns, inquire the perception of the patient, invite the patient for further information and knowledge, explain the complications in simple terms, acknowledge and address emotions, address management, assessment, and next steps, talk about red flags and answer questions, summarize and provide a strategy for further management. For the doctor involved, escalate to responsible consultant, seek alternative staff to manage the patient if function is compromised, second victim care, which includes assessment of needs and interventions customized to the individual. A debrief should be available but is not compulsory. Obtain medical legal support, personal support from family mentors or peers, professional support from psychologists or psychiatrists, and time off due to impaired judgment, loss of paperwork. Risks incurred by second victim includes dysfunction, adjustment disorder, PTSD, early retirement, substance abuse, and suicide. Complete incident report and documentation of the event in the patient notes should occur after the critical incident. For the team, there should be optional debrief and second victim care as above mentioned. For the department level, notify head of department. Morbidity and mortality meeting should be conducted. At the hospital level, there may be need to notify the National Health Council and facilitation of root cause analysis. A root cause analysis is a structured, thorough investigation attempting to determine underlying causes and contributing factors to errors. It facilitates analysis and drawing out of learning points. Stages includes getting started, gathering and mapping information, identifying care and service delivery problems, analysis, generating recommendations and solutions, implementing solutions and writing of report. Incidents will be categorized and investigated by level of harm, which includes no, low or moderate harm, severe harm or death, or severe harm, death or public interest, which includes never events. A fishbone model can be used to help identify the contributing factors. Components includes education and training, patient, individual, equipment and resources, tasks, work conditions, communication, team and social, organizational and strategic. How might the occurrence of errors be reduced? This includes latent and active measures. Latent measures includes use of automated systems, standardization of equipment and drugs, equipment design and function, such as ergonomics and forced functions, to improve patient safety. Active measures includes use of checklists, briefing and debriefing, updated guidelines, handovers, readbacks, simulation training, and double checks. What are NET-SIPs and LOC-SIPs? NET-SIPs are national safety standards for invasive procedures, and LOC-SIPs are local safety standards for invasive procedures. These have been introduced with the same theory behind WHO surgical safety checklists in order to standardize processes and protect patients from adverse incidents during invasive procedures. Setting up a new service template, for example, for epidural service, a mnemonic is 5A: assess, assemble, align, activate, and advance. First, assess the need for the service, baseline gap analysis and deploy data officers and auditors. Assemble, multidisciplinary governance team and assign roles, co-develop goals and objectives and protocols, employ cross-department education and training, set up committee staff and involve patients, planning for infrastructure, equipment, drugs, administration approval and financing. Next is align, set metrics and KPI compliance targets, activate protocol and digital tools such as electronic order sets, monthly audit feedback cycles for staff and patient, analyze outcomes and cost efficiency and publish dashboard trends. Last is advance, enable sustainability, institutionalize policy and financing, and rotate leadership roles. These are my references. Thank you.